I'd like to welcome you to episode 109 of Chairside Live. Early in 2014, red carpet regulars started showing up with a new haircut called the undercut. The undercut is short on the sides and longer on the top, and it was seen everywhere on heartthrobs from Brad Pitt to Kim Jong-un. In the dental laboratory, undercuts is a different thing altogether. Nothing that we're happy about. It's not stylish at all, but it does cross international and style borders, much like the haircut, the undercut. In our case of the week, we'll take a closer look at undercuts and how we're now dealing with them in a digital manufacturing world. After that, we're going to have a chance to see my interview with Dr. Erin Elliott. Dr. Elliott practices two of the things that I really love, and that is adult orthodontics and snoring and obstructive sleep apnea. In fact, she's really built her practice around these two growth centers, even though she continues to maintain doing regular GP things like most dentists do. She's up in Idaho, and we get a chance to talk about those two areas that she's chose to focus in and why they might be great areas for new graduates to get involved with when they get out of school and begin to associate with other practitioners. But before we do that, let's take a look at the case of the week. As you may recall from other episodes of the Case of the Week, there are certain stickers that you never want to see on your box when it's in the lab. And here's one of them, undercut. This is the summer of the undercut. We've been talking about this a lot. And it's really because it's not that it's anything new. It's just that we have a new way to look at it and a new way to evaluate it because of the digital technology we have and because of the fact that every time we receive an impression like this, we pour it in dental stone, and then we take it to the scanner and we scan it once it's in stone. So we pour the model and then it goes into our model scanner and we scan it. We begin to work on it in the digital environment because we love digital. It allows us to take a model like this, which is a prescription for a Brux or crown on tooth number 4, and immediately digitally design it and then mill it. But the issue, as you saw from the undercut sticker, was that we have some undercuts here. And as we look back and forth, visually we can see the undercuts as we try to be able to see all the margins at the same time. And when we scan it, it allows us to move around the path of insertion as well and see actually where the undercuts might be. And for example, in this model, so with this represents with the model sitting like this, as you can see in the scan right here. When we take a slice in it diagonally through this direction, right here through this part, right at the mesiolingual line angle, actually just a little into the contact from there, we can see we have an undercut there, 0.17 millimeters, which is 170 microns. And as we look towards the posterior on the distal lingual, we have an undercut of 200 microns there, and both of these undercuts exist and they're very difficult to deal with in a situation like this. And so there's a decision that has to be made here when we call the doctor, and the doctor needs to decide what they want to do. In fact, very minor undercuts, we're talking, say, 1/10 of a millimeter and less, you can usually make those work without having to do too much to the crown itself or the preparation for that matter. It really starts to get dicey as we get around 0.15 millimeters or 150 microns of undercut. That's where all of a sudden we aren't able to do what we'd like to be able to do. And of course, part of all this is based on the adjacent teeth. So if the adjacent teeth weren't here and all we had was the preparation, the Brux or crown that was milled would fit on relatively nicely and not be an issue. But of course, if we're going to set this in the model now, that's not going to happen because of the undercuts. That has not been stained or glazed or polished yet at this point, as you can tell. And so when we design a crown that has undercuts, the Bruxer mills will actually mill in an undercut. That's really not the issue. It's more the issue that the bigger the undercut gets, even though we can mill it into the crown will then not fit down onto the tooth. And so there has to be some adjustment made to the inside of the crown to kind of compensate for that. And that's where the difficulty comes in because it starts to play with the margin. So for example, if a dentist tells us to just kind of go for it. Like if we look at a preparation here, and we'll have a preparation, we'll have the margin come up like this and maybe end, and here's the root of the tooth, and the prep's going to come up, and the prep's going to come over, And as it comes over, we're going to have it really kind of undercut here. And that's where we're going to have our margin. It's going to be right along in here. But the undercut at the margin, which we see a lot of, is now below the height of contour, which is right about here. So if you tell the software to ignore it when it makes the crown, it will design a crown that's going to be a reasonable looking crown. And it will also, it'll come over here and it'll make it kind of look like it's supposed to look down to this margin over here, even though we have an undercut. But again, when we take this crown and mill it now, and it's now solid zirconia, pre-sinted so it's a little easier to adjust, when the adjacent teeth are here, this crown won't go down. So we need this crown to seat in a vertical direction, even though the path of insertion is over to the side. If we didn't have adjacent teeth, it would not be a big deal, but we have adjacent teeth. And so essentially what the technician now has to do is come into the inside of this crown and start grinding away at the bruxer at the inside of the crown until it negates the undercut. And the problem is when you do that, when you grind all of this away, you begin to open the margin down here. So instead of having a margin that's open, say, 50 microns, by the time you grind this away, this might be open 200 microns. And that begins to be problematic, obviously, when we have, even with a resin cement, we don't want to have a margin like that. But when a dentist says, do your best, see if you can make it go down, and I'll try to make it fit and use a resin cement. This is, in effect, what we're being asked to do, and we don't feel great about it. So that starts at about 0.15 millimeters, and that goes up all the way to about, say, 0.3 of a millimeter, 0.30 or 300 microns. If the undercut's beyond that, this won't even work. We'll still have to do a little of this, but we'll also have to give this doctor a reduction coping that's going to fit, onto this tooth. I'm sorry, this isn't a different color. And this reduction coping is going to have to come down across here, showing the doctor where they need to prep away all this tooth structure. We need a little more there. All this tooth structure to get rid of that undercut so the crown will fit. So we do a little adjustment to the inside of the crown, and the dentist needs to use a reduction coping on an axial surface, which is kind of difficult. Actually much easier to use a reduction coping on an occlusal surface for a cuss tip. So when we have undercuts and the dentist says go ahead and try it and see what you can do on a single unit like this, if it's small enough, we can just make an adjustment to the crown and hope it doesn't open the margin too much. We'd prefer the doctor fix the prep and take a new impression, but sometimes if it's big and the dentist just wants to try something in the mouth so the patient can see they tried it, we'll do the reduction coping as well, because now if the dentist does the reduction coping, tries the crown on it, still doesn't fit, he's ready to take a new impression to have a new restoration made. So that happens on single units from time to time, but much more frequently it happens on bridges. And again, this is a 3-unit bridge prep, and you can see pretty clearly here that we've got some undercuts there. If we look at the actual numbers themselves, you can see that on the mesial of the molar we have our 2 undercuts, and on the lingual it's going to be at 0.20, and on the buccal it's at 0.27. So again, we have 2 undercuts here on the molar, and you can see both of them marked with a red pencil right there. And again, we've got the gingival margin in the shadow of that undercut. And so for this to insert the way it needs to insert, yes, we can make an undercut, but the technicians have to grind it all away. So it's hollow in here, essentially, on the bridge to get it to go down. Because obviously, if we take out both these teeth, the bruxer bridge will fit on the 2 individual teeth. That's not going to be the issue. The issue is going to be as they start to grind away here, and you can see grinding away how it begins to open if the doctor's not willing to take a new impression. And I don't know if I just grabbed this actually off the tech's bench. I'm not sure if they're done with this grinding yet. Okay, they are done with the grinding. So it goes down, but you can see what it does to the margin when that happens. By definition, it's going to, when you go in and grind that out, it's going to open that margin to change that path of insertion. Really, the right way to change that path of insertion is, in fact, to go back and prep. Or really, the best way is to not have this happen in the first place. And at the end of this, I'm going to explain to you something we've been doing with a few select doctors that we're having some great success with. A little bit of a hassle, but it's a neat way to be able to avoid undercuts altogether. And so this is something that is more common and more endemic to bridges. Here's just another bridge that I happened to grab. So the more typical thing is that we see that mesial tilt to the lower molar, as you see there. But this one, we have a distal tilt of the second bicuspid as well. And so when we look at the scan of this model, we actually see a 0.26 millimeter undercut on the mesial of the molar and a 0.30, 300 microns on the distal of that bicuspid. And so this is definitely going to, again, there's the undercut area marked and the undercut area marked on the molar as well. And so yes, the bridge, can be fabricated, but it's going to take, it would take so much grinding here that there's just no way it would work. If I take these out, it's going to fit on each of these preps individually, but it's not going to fit on them simultaneously. And this is the example where even though a doctor says do your best, we're going to have to send a bridge that's been adjusted on the inside and reduction copings, especially on this bicuspid, so he can go in and straighten up that wall and tilt this back towards the mesial in order to have a chance of this bridge fitting. If it doesn't fit, just by straightening up this wall and putting a little more mesial angulation on it, he's going to be able to take a new impression, and we can make a bridge that fits at that point. So at least the doctor gets to try this into the patient's mouth and make a good faith college effort. And then when it doesn't fit, say, boy, the lab got something wrong here. I could play with this a little bit more, probably get it to fit, but I really don't want to Mickey Mouse this. I want this to last decades, not days, or years, not days. I tell you what, let's take a new impression and send it to the lab. I'm sure they'll get it right this next time. And usually the patient's going to be okay with that and not have an issue with it. So what have we been doing lately to kind of get away from this, from getting away from having these types of undercuts? Well, with some of our doctors who have scanners, and so far we've just been doing it with like a couple Sirona users, we've got doctors who, the way we have it set up now, we can actually share their computer screen on their scanner. And so when a doctor scans this, before they scan it, they can actually put the camera in the mouth while one of our technicians looks at it live here at the laboratory. And as we look at it live with the scanner and capture that image, our software, if their software won't tell them, our software will tell us where these undercuts are. And so very quickly we can see where these undercuts are, as if we couldn't see it when the dentist scanned it from the side. And we can say, doctor, can you go in and prepare the mesial of that molar and tilt that, angle that back towards the distal for us? And the doctor will go in and do that, dry everything off, put the camera back in again, and show it to us, and we'll capture that and put it into the software and say, that's good, just a little more right on the mesiofacial. And the dentist will do that, and then rinse it off, dry it off, put the camera back in, and we'll say, good, the undercut is gone. Go ahead and take your digital impression. In fact, we can stay on the line and watch the dentist take the digital impression and make sure they've captured all the information that we need. This is fantastic because when they send that original scan to us, or that original screen capture that we see as we see them move the scanner in and out of the patient's mouth in real time, the patient's still there, the patient's still anesthetized. This isn't getting them back, get the temp off, numb it up, and go back in and reshape these. It's right at that moment, and it's been a fantastic way for us to be able to help dentists out, because it's really like having a live laboratory technician in your office over your shoulder who's got x-ray vision and can do calculations like this about undercut in their mind. So we're getting to the point where we're closer to releasing it to everybody who has a scanner, where they have that capability. There was another guy the other day doing 10 maxillary anterior Emax crowns who was scanning the preps, and we were showing a couple areas, pointing out where he could do a little more preparation. And then once he took his digital impression, we showed him a couple spots where he could pick up just a little more by rolling the camera to the facial as he was doing the impression. And then by the time it goes to the laboratory, the preps and impressions are exactly where they want to be. So in the meantime, we're still stuck with dealing with undercut problems like this. And while there are a few things we can do to the inside of the crown, anytime we're asked to do that by a dentist, there's always a price to pay, and that price is opening the margin to a greater degree than it's already open. We're all shooting for 50 microns on our best day, and this will easily add another 100, 150 microns to that if a dentist asks us to do it. So it behooves us to try to get this right and try to make sure that we look in the mouth with our one eye closed in our mirror, trying to see if we can sight down both of these down a path of insertion. Short of that, again, we're happy to send reduction copings to help you get this right, and even send a bridge along so you have something to try into the patient's mouth, and then blame the lab. We'll take the blame on that one as the faceless laboratory. And hopefully as more dentists get scanners, we're going to see a move towards that virtual dental technician, where the technician is watching your case as you prep the case and is able to give you feedback in kind of real time to tell you whether or not you've got an undercut, what you can do to correct it, and when you're finished, and they'll be able to fabricate a bridge. I'm happy to have with us today Dr. Erin Elliott, who I met not too long ago when I was up at the Idaho State Dental Association meeting. And as Erin told me more about her practice, I really liked what she had to say about it, because I think her two areas of emphasis, at least the two that we talked about, are great areas for any dentist getting out of school today, or for somebody whose practice has slowed down a little bit and they want to revitalize it. And there are two areas of dentistry that are kind of near and dear to my heart, because one of them I used to do before I came here, and of course the other one we do here all the time is we make lots of appliances. And so I'm referring to orthodontics, kind of specifically accelerated adult orthodontics, and snoring and sleep apnea, two areas that I think are traditionally kind of ignored by general dentists, but hopefully we're going to find out from Erin that these can be great potential growth centers and profit centers in your office. But before we get to that, Erin, let's go back to dental school and tell me a little bit about what inspired you to become a dentist, and how you perceived dental school, and then what you did when you got out to get where you are today.
Well, my dad is actually a dentist, so it is in the family, but I never had those expectations. He practiced in Long Beach, California.
Yes.
And I grew up in Orange County, so that was a little bit of a commute. So I didn't grow up hanging out at his office or anything. Went away to college in upstate New York and figured, I was always going to have a career in the health area, but dentistry was for me, and I absolutely fell in love with it.
And so was there so you knew, like my dad was a dentist too, and his practice was 3 miles from the house, but I didn't spend any time there either. I went when I needed to borrow money. It was not really borrowing. I had no intention of paying it back. It was more taking money. But really it was it was just kind of the lifestyle where, we took maybe a little more vacation, and he worked 4 days a week, and those were really kind of the things that attracted me to it. It wasn't like I hung out at the office and watched an extraction and said, now that's what I want to do. What was your experience like in dental school?
Well, I went to Creighton, and I absolutely loved it because there was no specialties. So if I wanted to go place an implant, if I wanted to do third molar extractions, I got to do it. Molar endo, pretty much anything. I always felt like they held me back, though. So I'm like, it's not going to take 3 hours to do a class 2 amalgam. So I felt like I was ready to go when I graduated 11 years ago now.
11 years ago, yeah. You're not gonna brag, but I happen to know you did very well and placed very highly in your class, much higher than I did. So maybe they were holding you back, in many different ways. So when you got out, did you just start doing kind of the regular day in, day out, bread and butter general dentistry stuff like most of us do, or were you immediately kind of attracted to some of these other areas of dentistry?
Growing up, whenever I did go to my dad's office, I thought, I think it's all the girls that do the work. No, what does he actually do? And then I realized I was an associate in a small general practice in Post Falls, Idaho. My professor told me one time, Elliott, that's what everyone called me, Elliott, I didn't know you were smart. Why aren't you specializing? And really, honestly, it's because I like to do everything. And I knew I could pick and choose what I wanted to do. And it was probably about 5 years ago that I discovered that dentists can be a part of this sleep apnea wheel, and started in that because I really like to sleep myself.
That was the attraction, was you love sleep, you want to help other people to sleep as well.
But I love doing bread and butter dentistry. I still do. I still pull teeth. I just came in this morning at 6:45 and met a patient to pull teeth, and I am in Idaho.
Nice. What did you use? Were they difficult extractions? Were these just elevator forceps, or were you using like luxators or approximators?
Elevator forceps and some physics forceps as well, because they were pretty broken down.
Nice. I like those physics forceps. You're a fan of them too?
I do too. As long as you use them correctly, they're beautiful.
Yeah, I completely agree. Well, that's neat because it's funny to hear the instructor say, "You're smart. Why don't you go into a specialty?" That's almost kind of an insult to to
I
GPs.
think so.
Right. It's like they pull somebody to the side and go, "You're dumb. Don't consider any of the specialties. Just be a GP." Because honestly, what do you have to be smarter to do? Know how to do 9 different things, or just do nothing but endo all day? You know what I mean?
Yeah, I don't envy the endodontist at all.
Right. So the great part of being a GP
Yeah.
is getting to do lots of different things. And then there's even GPs though who are so attracted to one thing that they decide that's what all they're going to do. Like my good friend Brock Rondeau up in Toronto, Canada, is a GP who does nothing but ortho. Well, now he does some TMJ and snoring and sleep apnea.
Yep.
But for the longest time, it was just doing ortho. And you just can't say your practice is limited to orthodontics. But snoring and sleep apnea, we make a lot of appliances here. And I think for the dentist who's just barely dipping their toe in the water when they want to make a snoring appliance, they might send it to us. Most of the RXs we get from doctors for their first snoring appliance, the patient's name and the doctor's name are exactly the same, and so we can tell that it's probably for the doctor himself after
For
the
the
wife.
guinea pig.
Yeah,
Yeah.
or the wife's been complaining for the last 20 years about snoring, and then finally he breaks down and decides to make one for himself. As I got involved with it, I noticed that it was kind of this weird area of healthcare where doctors learn nothing really about it in medical school, and we learn nothing really about it in dental school. And so these poor people suffering from obstructive sleep apnea are kind of caught in between the professions, and it really seems like that for dentists to be able to step in with oral appliances, that is a great way for mild to moderate obstructive sleep apnea. So when you first got involved and decided, I like to sleep, I want to help other people sleep, what were your very first steps? I mean, did you make an appliance for yourself first, or did you go to a class first, or how'd you go about it?
I think my husband would wish I would make myself an appliance. There's a couple of videos floating around social media right now with me sleeping and snoring. But actually, I knew that there was more to it than taking impressions and handing over an appliance. I knew that we were treating a medical condition. So I didn't really want to mess around with creating a silent apneic, someone that is quiet. You address the chief complaint, but yet they're still having sleep apnea. So I started out actually with Kent Smith's course down in Dallas, and my dad came with me. He, as I said, he was a dentist, but he had since retired and just loved dentistry so much. He's like, I think I'll come with you. And I was like, okay, as long as we don't share a room. But I'm cheap, so I did. But it was miserable because he snores. That's all we knew. My dad snores. He snored his whole life. So as part of the course, we did a home sleep test, and I actually don't have sleep apnea. It's just, a couple glasses of wine.
Right. Relax all that soft muscle,
Yeah.
all the soft tissue and everything goes. Now, did your dad what did he measure?
He ended up having severe sleep apnea. The scariest part was seeing his heart racing all night long, bradycardic. He got up to 139 beats per minute, and for those of you crazy triathletes, you know that that's kind of a training mode. So it scared me really because he was supposed to be resting, but his body was working overtime. He was running a marathon without the benefits of running a marathon.
Now, what did your mom say? Had he been snoring for the last 10, 15, 20, 25 years?
Oh,
And
yeah.
they just thought it was snoring though and left it at that.
Yeah, it's normal. Dad makes noise, We go camping in the summers, and it was miserable. I like my sleep, so he was interrupting it. And we made him there was an appliance made as part of the course, and we decided, of course, he didn't know what the heck he was doing when he said it. It wasn't in the necessarily proper position, but even that first night, his heart was resting, and he was quiet. And we were able to titrate him to actually normal. And my mom actually thought he was dead the first night because for the first time ever, he was quiet.
She was calling the paramedics over like every night for the first week or two, checking his pulse.
Yeah. Well, good thing she's a nurse, so she was able to resuscitate him.
Now, I think one of the things that holds dentists back, like if I had to take a guess, we made literally tens of thousands of sleep appliances last year. And I would guess that the vast majority, and I hate to say it, but I think the vast majority were done without an at-home sleep test or a sleep lab study. I think that's one of the things that kind of holds dentists back from getting involved with this, because the idea of having to, I don't know, manage maybe the case and send them to a sleep lab or send them home with this device to wear. But I have found that it's really not that big of a deal sending people home to wear one of these at-home sleep tests. How do you feel about it?
It's really not. The potential in our own practices is huge. I did in-office training with my staff, and I probably get at least 2 consults a day just out of hygiene. And of course, there was a study that showed that of the 100 people that were sent for sleep studies, 30% of them didn't go, even though we knew 82% of them were going to be positive and severe. But the whole reason they didn't go was because they didn't want to wear a mask. And then the other percentage didn't want to go because they didn't want to sleep overnight. Well, guess what? If you remove those hurdles, your patients are all of a sudden like, okay, I'll go. I don't have to wear the mask. Maybe I can wear an appliance. I don't have to go sleep somewhere, strange. I actually did go do an overnight study, and I loved it because I'm a working mom, and my husband didn't monkey with me. It was just peaceful.
So getting a night away from the family was actually pleasant, even though some guy with bad facial hair and a couple tattoos was staring at you all night while you were sleeping.
And the camera's small. I forgot about it.
By the way, are you saying that if I Google Erin Elliott snoring, that there's a video floating out there where I can actually watch and hear this for myself?
Not yet.
Okay.
My husband used a foul word, so we have to make it PG.
Oh, I'll be happy to use our technology to bleep
he was
that
annoyed.
I can only imagine that. So, yeah, it's not a big hurdle to send him home with that, because it's such a comfortable way to do it. Well, what I'm really interested in hearing about, if you're able to get 2 referrals at a hygiene a day, your hygienist must have some pretty good verbal skills and be familiar with what to look for on these patients?
Yeah, screening is tantamount. You can change your health history to ask if, a patient has had sleep apnea. I think it's more subtle, too, because as we know, not every patient is as in tune with their health as they should be, but even to ask whether they've been told to go get a sleep study or been referred, or if they've been told to wear a CPAP and don't. Because you could ask, do you wear a CPAP? And they'll say no. Well, that doesn't tell you that maybe they were told they were supposed to. But the hygienists, they know to look what medications to look for. High blood pressure medications, acid reflux medications. We check blood pressures all the time. There's a lot of clues, and then you can see the dental clues. High arched palates, mouth breathing, acid erosion, scalloped tongue, small airway. They're sitting there for an hour. I go in for, with my great skills, it's 30 seconds. But they are sitting with them and bonding, and usually we know their spouses too. So we do have some spouses that say, hey, Jim's coming in next week. Talk to him about his snoring. We do ask if they snore, but sometimes a lot of patients will say, no, I don't, but my wife says I do. In my case, my husband says I do, but I don't. Also, we ask when you wake up in the morning, because it's the petite women that don't necessarily snore, but we'll say, do you feel refreshed when you wake up? And they'll look at us like, are you supposed to? Well, yeah, you are. So we lead into the question. Sometimes it's just planting a seed, and most of the time, by the time we're done, and I come in and confirm it, the patients are like, help me, I'm ready to go. So it's really been easy that way. What I really like are the faxed over referrals, because the patients are usually met their deductible, they're diagnosed, and they're desperate for help. The low-hanging fruit, as you say.
Where are they coming from?
Physicians, primary care, nurse practitioners, sleep physicians. Kind of doing this for 5 years and being in a smaller community, as soon as you get in front of the physicians and even treat some of them, it's amazing how many referrals you can get.
I think that's probably another area that makes dentists a little nervous, is having to go and maybe talk to physicians who sometimes are seen as
higher than dentists, at least if you measure the number of network TV shows about medical doctors compared to dentists. And so I think maybe they're afraid to go out and talk to them about this, or like you said, treating them is fantastic, or the nurses. Did you actively go out and kind of court these different groups in order to educate them?
I like that word, court. Yeah, I would use it any in I had, really. Just as soon as you can get face-to-face with them, which is the hardest part, they'll soon see that they really don't know a whole lot about sleep. Of course, the sleep physicians do, but they don't know how to screen for sleep apnea. They don't ask those questions. They put their patients on high blood pressure medications or diabetes, type 2 diabetes, and send them on their way, when a sleep study, it should be one of the things that they're getting. And just making them aware of that has been really fun as well. Just getting more people more help. But yeah, you do have to hit the street a little bit, the pavement, but it's fun for me.
Part one of my conversation with Erin. I really think that if I was a recent graduate coming out of school these days and I was going to associate with another dentist, what a great thing it would be to be able to go into that practice, and rather than wait for the senior doctor to kick some crown and bridge my way, what if I could go in and do a procedure that the senior doctor wasn't doing yet, like 6-month smiles, or like treating patients with obstructive sleep apnea. Now I'm not only creating revenue for myself, production within the practice, but I'm bringing in production that wouldn't have been there before. That's got to impress and really get the attention of the senior doctor, and probably have the senior doctor thinking, you know what, this associate might actually be able to purchase his practice one day because he's creating new revenue that wouldn't have been there otherwise, rather than just saying, please, oh please, can I have a couple 3-unit bridges. So we'll look forward to part 2 of my talk with Erin Elliott on the next edition of Chairside Live. On behalf of everybody here at the laboratory, the CSL crew, I'd like to thank you for your time and your commitment to quality dentistry.
James. Yeah, I'm talking to you. Turn off your microphone, dip. It's still on. We can hear you whispering. Even though some guy with bad facial hair and a couple tattoos was staring at you all night while you were sleeping.